My name is Dr. Neil Iyengar. I'm a breast medical oncologist, co-director of the Breast Medical Oncology Program and director of cancer survivorship at the Winship Cancer Institute of Emory University. I'm delighted to be joined today by my friend and colleague, Dr. Komal Jhaveri. I'll let you introduce yourself, Dr. Jhaveri.
Thank you so much. I'm Komal Jhaveri, a breast medical oncologist from Memorial Sloan Kettering Cancer Center in New York. Your prior institution, Dr. Iyengar, we miss you. And I'm the section head for the endocrine therapy research program, and I'm an associate attending with dual appointments with our breast medicine and early drug development services there. So pleasure to be here today.
Wonderful. Well, thank you. So we've seen a lot of data for the treatment of HER2-amplified breast cancer, yes, both in the metastatic setting and now in the early stage setting. And I'd like to have a conversation with you about how we contextualize and even implement some of the recent data sets in the early stage setting. Why don't we start in the neoadjuvant setting, where we've seen the DESTINY-Breast11 trial, and looking at the question of whether we should be using an ADC regimen with trastuzumab deruxtecan and THP in the neoadjuvant setting versus standard of care, although we can have a discussion about the definition of standard of care. But Dr. Jhaveri, could you walk us through DESTINY-Breast11 and what struck you in terms of the results from that trial?
Yeah, no, absolutely. So I think, we've seen robust activity and robust efficacy, and we have approval for trastuzumab deruxtecan, obviously, in the metastatic setting. Both in the late-line metastatic setting, we saw data for T-DXd in patients with metastatic brain metastases as well in the DESTINY-Breast12 trial. More recently, we've seen the first-line metastatic study with DESTINY-Breast09, where again we saw an unprecedented progression-free survival benefit as well for T-DXd plus pertuzumab. So the natural next question was, should we be thinking about utilizing this drug upfront in the early stage setting, and would that lead to further improvement in outcomes or optimization of outcomes for our patient? So DESTINY-Breast11 is a neoadjuvant attempt where we had 3 arms. We had T-DXd monotherapy, which was administered for 8 cycles, so every 3 weeks, 1 cycle for 8 cycles. We had the combination of T-DXd with pertuzumab, and then we also had a sequential therapy after 4 cycles with THP. And the comparator arm really was for our high-risk patient population, an anthracycline taxane-based regimen with dual HER2 blockade, so ACTHP. The primary endpoint was to look at pathological complete response rates. And when historically we think about what do we expect with neoadjuvant therapies with HER2-positive breast cancer when it comes to PCR, I think we think about somewhere between 39 and 60%. And what we saw, at least right now, the IDMC really held the monotherapy cohort because I think the efficacy that they saw, the PCR rates that they saw, did not necessarily were going to beat the ACTHP arm. And so that was something that they had shut down last year in 2024. But when we looked at the T-DXd followed by THP, that arm really yielded a PCR rate of 67%. And this included patients with hormone receptor positive and hormone receptor negative breast cancer. This was high-risk patient population, stage 2 and 3 breast cancers. And when we're talking about high risk, if you had a larger tumor size, so if you had a T3 tumor, you could even be node negative. You could certainly be node positive. If you are N1 to 3 nodal positivity, you could even have a smaller tumor size up to T1. So this is really your patient population that you see contemporarily in clinic. It's stage 2, stage 3 breast cancer, where you would offer them neoadjuvant therapy, and you're trying to compare an anthracycline-free regimen to an anthracycline taxane-based regimen, where you show superiority for pathological complete response with this approach. The PCR rate in the hormone receptor positive group was 61%. Again, very respectable and higher than what we've seen with HR-positive breast cancer. And for HR-negative was 83%. Again, unprecedented and very impressive results, even in that cohort of patients. And while the study is not powered really for event-free survival, we did see an early signal already with 10% maturity of the data. We're seeing a trend favoring, the dual approach of sequential T-DXd followed by THP with event-free survival, which is very reassuring as well. Now, in addition to the efficacy, of course, safety is really paramount, especially in the early stage setting. And it was very impressive to see that with this anthracycline-free approach, we saw much better safety profile compared to an anthracycline-based approach. And ILD rates, which we really want to worry about or think about more judiciously with T-DXd-based regimens, given what we've learned about them in the metastatic setting, with 4 cycles of T-DXd, those rates were much lower. So 4 to 5% ILD rates. So I think overall it was a win. We've been able to beat the bar of historical PCR rates. We're now able to consider for a high-risk patient population an anthracycline-free regimen. We're actually able to have a very tolerable and a better safety profile than what we have had for patients with an anthracycline taxane-based regimen. And ILD rates are rather respectable or lower, which is reassuring. So I think overall, very impactful data.
Wonderful. What a comprehensive and wonderful summary of the data set from DESTINY-Breast11. As you commented, I'm very impressed by the PCR rates, and really remarkable in the hormone receptor negative setting to see a PCR rate above 80%. But let's talk about PCR for a minute here. And you highlighted importantly that the trial was powered to a PCR endpoint, not necessarily an event-free survival endpoint. I think when we talk about PCR as a surrogate of long-term outcomes, certainly in the hormone receptor negative setting, we've seen good concordance with long-term outcomes. And in the HER2-driven setting, the concordance rate is apparent. But what are your thoughts about the PCR rate in the hormone receptor positive group? Is that a group that you would apply the data to? Are you impressed by that PCR data, or is this something that you'd like to see longer-term outcomes or follow-up?
I think the data were impressive for both cohorts. I do think that when we think about hormone receptor positive group, traditionally, also historically, also, we're thinking slightly lower PCR rates. But the 61% PCR rate that we've been able to achieve in this study is definitely higher than what we've been able to achieve with other studies as well. And so to me, it just makes sense to not necessarily break this data down by hormone receptor status, but if I'm thinking about a neoadjuvant approach, to apply it to both cohorts of patients, because I do think that the PCR was impressive.
Absolutely. I couldn't agree more. I mean, I think that we can't underestimate the PCR benefit here, because, of course, it translates to so many subsequent quality of life related issues in the post-surgical setting, right? The burden of a nodal dissection and potential complications thereafter, the use of radiation therapy and so forth. So I think there are a lot of consequential ramifications from this data set. You did highlight the adverse effect profile and the toxicity, and I think we were really quite reassured to see no grade 5 events or deaths related to ILD.
Yes.
Could you tell us a little bit about the toxicity that was seen, the general adverse effect profile, and how you manage or will manage adverse effects associated with the regimen?
Yeah, so I think the good news was there were no surprises. So what you would have expected for trastuzumab deruxtecan side effect profile is what we have seen as well. We talk about the nausea management, and I think that would still be important, and I think that was something that was definitely seen more so also with this regimen as well up front. We did not obviously see a higher rate of ILD, given that we're giving only 4 cycles, which was, I think, very nice to look at in terms of what distinction it had. Very reassuring that we don't have deaths. This is early stage setting. We definitely don't want therapies that can lead to fatal outcomes, which is a good thing to see here. And from an anthracycline taxane-based regimen, again, the expected side effect profile is what we were able to see. But I think overall, all the toxicities that we saw looked better. We have updated data for safety at this meeting as well, to talk about DESTINY-Breast11 safety. And again, as I said, I think looking at a regimen that we rely on for our very high-risk patients, which is an anthracycline taxane-based regimen, and having an option which looked better, safer from a toxicity perspective, I thought was very reassuring for our patients in clinic.
Absolutely, couldn't agree more. And let's talk a little bit about that control arm, because there has been some discussion about an anthracycline-based regimen, and certainly you and I both grew up and trained at the same place, and we certainly use anthracycline-based regimen. This is high-risk disease, after all.
Yes.
So I will say that I personally think that this is the appropriate regimen for the control arm, but what are your thoughts about the control arm in terms of the study design?
Absolutely. We belong to Northeast together. I still belong to Northeast. You moved south a little bit.
That's right.
But we're not on the West Coast, so I think we still have some belief, I think, in the anthracycline-based regimen, and I think I completely agree with you. I think, we used to think that anthracycline was the only way to go. And then we have non-anthracycline regimens like docetaxel carboplatin and dual HER2 blockade that we utilize. I think we have adapted that into our practice with data that has shown non-inferiority approaches for those regimens. But I still use anthracycline-based regimens for our highest risk patient population. And yes, you can have slightly more cardiotoxicity or a secondary leukemia. Thankfully, those rates are lower, but they still are present, and we discuss that with our patients. But it's not that a non-anthracycline docetaxel-based regimen is actually much easier or a walk in the park. I mean, they have their own distinct toxicity profiles, and I think we've been able to show non-inferiority. There's no data set that tells me that using docetaxel carboplatin HP is superior than anthracycline taxane-based regimen. So in my mind, I think this control arm is still very appropriate. I am not necessarily discouraged by the fact that this was not. I'm not necessarily convinced that if it was a non-anthracycline-based regimen, maybe the safety profile of T-DXd and THP would have looked worse. So I'm not necessarily bothered by that. I think this was appropriate. I still use it. I have adapted PCHP in my practice. I would use that too. And DESTINY-Breast05 allowed both for the right reasons, because we are using both kinds of regimens for a right patient. It's just that we're using more of TCHP than we did before. So I think it is a very appropriate regimen from that regard. And I think my impression of the data does not get impacted by the control arm.
Absolutely, couldn't agree more. And I think when we see such a dramatic delta difference between the two arms, it's hard to imagine that a different control arm would produce much of a different conclusion. So thank you for walking us through that. Let's talk about the patients who maybe did not achieve a pathologic complete response. Maybe let's start by laying some groundwork here. And could you talk a little bit about residual cancer burden and how you are using or maybe not using RCB to guide your practice?
Yeah, no, I think, residual cancer burden is very interesting. It can be a little tricky for all pathologists to actually spend some time. It is a little cumbersome for pathologists to do that. So do our institutions routinely do it, or do all institutions routinely do it? No, they necessarily don't. But we have been going with just residual disease that has been reported out post-surgery in the pathology reports and going by that. And that has been what has been utilized in trials as well for eligibility criteria. So currently, our current standard of practice is neoadjuvant-based approaches, just because we want to try and get that PCR level. If we don't get pathologic complete response and have residual disease, we have the Catherine data that showed us not only invasive disease-free survival benefit, but now has also shown us overall survival benefit with longer follow-up with utilizing TDM1 or radiotrastuzumab emtansine in the residual disease setting. And so, but now we also have data coming out from DESTINY-Breast05, which is not surprising at all that T-DXd was superior than TDM1. I mean, certainly we've seen that happen in the metastatic setting. We saw that with DB03 as well, where patients who got T-DXd had a better benefit than TDM1, and that has replaced our second-line approach, or had replaced T-DXd with the TDM1 in our second line. So using that same thing in DB05, I'm not surprised that we've been able to show superiority for T-DXd. But I think when we think about DB05, who were those patients? I think Catherine obviously allowed a lot of patients that achieved a lot of benefit with that approach of TDM1 residual disease, but there were still those patients whose outcomes could be further optimized, because if they had residual nodal disease burden, they were somebody who would probably have a lower IDFS rate than somebody who did not have that residual nodal disease burden, or the larger tumors definitely did not achieve a similar degree of benefit in IDFS rates. And so it was very nice to look at DESTINY-05, which focused on that highest risk patient population. So inoperable tumors, or if they were operable, they had to have residual nodal disease burden. And then those patients were then randomized to receiving T-DXd versus TDM1 for an invasive disease-free survival benefit as a primary outcome. And lo and behold, it was very impressive. Hazard ratio was 0.5, showing superiority for T-DXd over TDM1. Very impressive data. And also, disease-free survival was also something that we saw in the trial. And again, benefit seen for T-DXd, not surprisingly, over TDM1. So I think very impactful data there as well. The trial did allow patients to have received any kind of neoadjuvant therapy. There were patients who got anthracyclines. There were patients who got non-anthracycline or TCHP-based regimens, and then get randomized and still show benefits. So really applicable for anybody with inoperable tumors or residual nodal disease, where we would want to offer these therapies and derive the benefit that they did.
Well, thank you for walking us through DESTINY-Breast05. I think absolutely an impactful data set there. Before we move away from the neoadjuvant setting, I just want to highlight a point that you made, because certainly we're impressed by the PCR rates in DESTINY-Breast11, but you also alluded to the more favorable outcomes, even for those who have some residual disease, but maybe less so, so our RCB1s or even 2s, for example. And to see a shift, even in the residual disease setting, to the lower end of residual cancer, RCB1 and 2, I think portends very well for the longer-term outcomes, including EFS. And even at this early phase, EFS is showing a favorable trend. So I think we're going in the right direction with T-DXd in the neoadjuvant setting. But before we move away from the neoadjuvant setting, let me ask you another topic that has come up quite a bit, and that is this sense of an adaptive approach.
Okay.
And certainly there are trials that are testing an adaptive approach, and this was not necessarily the design of DESTINY-Breast11, but I think you and I both get asked whether or not we're going to try to start off with THP, image, and then go to T-DXd, or vice versa, T-DXd, image, and then go to THP. We have to be careful because the trial DESTINY-Breast11 was not designed to answer that specific question. But how do you counsel colleagues who are asking you about a potentially adaptive approach in the neoadjuvant setting?
Yeah, it's such an important question, and I think it's certainly something that we want to explore further and understand the implications of further. I would say we have trials looking at that. We have trials such as Compass HER2, which gave THP and then decided based on residual disease to allow you to do more therapy, to allow you to do interventional therapy, which was in addition to TDM1, to Tucatinib, as well as a combination. Outside of the clinical trials, while it's very tempting, and while I want to continue to optimize management for our patients and give them as little as possible to derive the most benefit, I think we have to take a step back and caution ourselves with multiple things that we need to think about, right? I think we have all appreciated that, yes, PCR can translate into long-term outcomes, but we've also appreciated the fact that not all PCRs are the same. The second point that I would make is when we think about the THP-based regimens and we think about what kind of PCR rates we achieve, I think THP-based regimens have given up 43% of PCR rates. So certainly with the T-DXd followed by THP approach in DB11, we have gotten PCR rates of 67%. We've gotten a higher HR-positive PCR rate. We've gotten 83% with HR-negative PCR rate. So the point I'm making is I would love to have a biomarker, whether it's a clinical imaging biomarker, whether it's newer genomic assays such as HER2-DX that are being explored as well in many trials, which have prognostic implications, have not necessarily proven predictive implications. I would love to understand maybe if ctDNA or molecular residual disease assays can be utilized to further optimize a way of identifying the right patients. We have examples like the FORGAIN trial, which looked at FDG PET as well. I don't think I am ready personally to use that for all my patients to try and spare them 4 cycles of T-DXd that DB11 give. I think 4 cycles are manageable. The safety profile is great. The efficacy is wonderful. Unless I have very robust data of who I could really pick out very comfortably to avoid this for, my question is, why should I not do this? Because it's giving me good efficacy, decent safety profile. So I think for my practice, I'm not ready to do that adaptive approach yet.
Well said. So certainly a lot of potential, but we're not quite yet there. And
Exactly.
So following the trial design as it was carried out is the prudent approach.
It could be our future. I don't know if it's our current present. And I think it's a very doable regimen. And I think we're able to achieve the efficacy. Ultimately, we all want great outcomes for our patients. We want to try and figure out who we could spare more for, but not at compromising what we currently can achieve.
Absolutely, especially for a high-risk population,
Absolutely.
as you pointed out. So we're going to move now to the adjuvant setting, and we've been alluding to, but now we'll talk about DESTINY-Breast05. We've seen the data and discussed the data in the neoadjuvant setting, but also now we have exciting data in the adjuvant setting. Dr. Jhaveri, could you walk us through DESTINY-Breast05 and the results that were particularly striking to you.
Yeah, no, absolutely. So I think let's start with what did we do, and what does DESTINY-Breast05 come in and actually replace, or will replace very shortly once available for our patients. So currently in our practice, we offer for any tumor that's either node positive clinically or a T2 sized tumor, neoadjuvant based approach. And that could be, we are using a lot more of non-anthracycline based approaches such as TCHP, but we still use anthracycline based approaches wherever appropriate for our patients. And then once we have that neoadjuvant based approach for a patient whose tumor achieves pathologic complete response, we certainly continue just maintenance-based therapy for the rest of the year. For those with residual disease, we have the Catherine data, which showed us that utilizing T-DM1 for residual disease leads to not only an invasive disease-free survival benefit, but also an overall survival benefit with long-term follow-up that we heard from Dr. Sibyl Leubel. And it's now available and published. And so certainly we have been using T-DM1. DESTINY-Breast05 tried to ask the question, can we do better than what we've been able to achieve with T-DM1? Despite having T-DM1 and benefits in IDFS and OS, there are still groups of patients with high-risk tumors, such as inoperable large tumors, tumors with residual nodal disease burden, that have lower IDFS rates than their counter-halves, which did not have those clinical presentations. And so could we even do better with that? And could we potentially expect something better from a drug that might do better than T-DM1? And we asked that because we've seen that in the metastatic setting. We've seen DB03 show us that T-DXd has superior efficacy compared to T-DM1, and that's what replaced T-DM1 in the second-line paradigm for metastatic breast cancer. So DB05 looked at this high-risk patient population. They looked at patients who have inoperable tumors. If they had operable tumors, they focused on those tumors with residual nodal disease burden. And so these patients could have had any kind of neoadjuvant therapy, anthracycline or a non-anthracycline-based approach. If there was residual disease, they get randomized to receiving T-DXd or T-DM1. The primary endpoint was to look at invasive disease-free survival. And what we saw as the data readout was, yes, surely there was a benefit to the T-DXd arm compared to T-DM1. The hazard ratio was 0.5. Very impressive invasive disease-free survival rates at 3 years. And then we also saw disease-free survival benefit, which was also very impressive. So great data set, very mature, very impressive data to show us that for this high-risk patient population that are inoperable or have residual nodal disease burden, we should be offering T-DXd, and I'm hoping that that will reflect in our standard practice once available.
Great. Well, thank you for walking us through that data set. Certainly an impressive hazard ratio there at 0.5, as you've highlighted. Let's talk a little bit about safety. Could you walk us through the adverse event profile in DESTINY-Breast05? Was there anything that stood out to you or surprised you in terms of safety signals?
Yeah, no, I think, again, very important for us to think about not just efficacy, but also thinking about safety and quality of life for our patients. So one thing that I should point out for residual disease, at the back end, not only did they receive the systemic therapy randomizations, but you could also do other standard of care interventions, such as radiation. And in fact, when we talk about radiation, you could have had concurrent radiation with T-DXd, you could have had sequential radiation with T-DXd, you could have had endocrine therapy, and so you could have done what you would have normally done in the residual disease setting. And so because we were doing that, we obviously also looked for ILD pneumonitis or pneumonitis risks by following these patients with CT scans every 6 weeks as well. So there was certainly a signal for a higher rate of radiation pneumonitis that we saw. T-DXd is given for 14 cycles at the back end. We did see a higher rate of ILD, not higher than what we know about T-DXd, so same 12% rate. But when we think about early stage breast cancer, we have DB11, where we've used 4 cycles of T-DXd, where we saw the ILD rates for 4% or 5%. Here, understandably, because we're offering 14 cycles of T-DXd, we saw a slightly higher rate than TB11, but in line with what we've seen with ILD rates with T-DXd overall, so 12%. There were 2 deaths on study, and so that's something to keep an eye on or note of, because we can certainly look for these issues and try and avoid that, obviously, for early stage breast cancer. No other newer signals, if you will. We know about the nausea, we know about the fatigue that we can think about with T-DXd.
when we think about 14 cycles, I think we all agree and we all have faced that with our patients in clinic. When you have TCHP or anthracycline-THP, some patients are not able to get the full intended 14-cycle course in the residual disease setting, even with TDM1. And I think that was reflected in DB05 as well, where I think both arms landed up getting not the intended 14 cycles, but similar amount of cycles, because it gets a little challenging for patients to get so much therapy for such a long time, and there are limitations to that strategy. So those were the few safety things that really struck and stayed with me in terms of what I need to do. I have to make sure that imaging is obviously picking up pneumonitis and look at the pneumonitis rates, manage the nausea optimally and better, and then see what more supportive management can we do for our patients at the back end.
Well summarized, and I think your point about monitoring for ILD, even though the ILD rates were consistent or even lower than what we see in the metastatic setting, of course, is very important in the curative setting as well, so those Q6-week scans are important. Let me ask you, when you're counseling a patient, how do you frame the risk-benefit ratio, if you will, when you're offering, or when you will be offering, T-DXd in the residual disease setting?
Yeah, no, I think if I have a patient that I'm seeing in clinic with residual nodal disease, or if I had an inoperable tumor that had received, upfront therapy and has residual disease, I think it's very important for us to highlight the impact that adjuvant therapy can have. And we've had overall survival that we have been able to see with 8 years of follow-up with TDM1. We've known that T-DXd has shown superiority to TDM1 in the metastatic setting, and we're already seeing the IDFS benefit. So it's very, very important for us to tell our patients, yes, I'm sorry, we did not see a pathological complete response, but the good news is we have effective therapies that can have survival implications. So I think it's very important for us to highlight that to our patients. I would certainly do that. I would have to discuss with them what I need to do for monitoring and what kind of side effects to profile and support them with maximal supportive measures for nausea, for fatigue, and monitoring of pneumonitis. But I think very important for us to offer this in the residual disease setting.
Well said, and I think it can be challenging to talk about a treatment that has a rare but potentially fatal adverse effect with
Absolutely.
ILD, but I also think, as you've pointed out, on the flip side, it is the curative setting, and this is our chance to cure the disease, so we should lead with our most effective therapy to cure the disease.
Absolutely.
Well, let me ask you a little bit further. You've nicely commented on the patients who qualified for the trial.
Yes.
Now, when you're sitting in clinic, or how would you counsel our colleagues in terms of patient selection for adjuvant T-DXd? Are you offering it to everybody with residual disease, or are you sticking to the trial criteria?
Right now, I think I'm sticking to the trial criteria. The reason I also say that is, if I am seeing a patient who's just newly diagnosed, and if I can apply the DB11 criteria as well to that patient population, I think that's a reasonable approach to do, because, as we said, we're sometimes not trying to hold back to therapies at the back end. We're trying to use our effective therapies up front as well. 4 cycles of T-DXd followed by THP and DB11 definitely gave me a very respectable PCR rate. Yes, we don't have the EFS data, but we also know the totality of data with T-DXd. From the metastatic setting, from brain metastases, from DB05, I feel like we know that this drug is effective. We know that this drug works, that it's a very respectable PCR rate and very early trend of EFS that we're seeing. So I do think that it's possible that I'm going to offer the DB11 strategy. And because I would do that, I feel like I am right now thinking about offering the DB05 strategy to the DB05 eligible patient population.
Yes, that makes sense. And I want to talk a little bit about a point that you raised, and that is the CNS activity.
Yes.
I think we were excited to see the overall survival data from Catherine, as you've highlighted, but also a little disappointed to not move the needle further in terms of CNS recurrence in Catherine.
Absolutely.
Now, when we look at DB05, what are your thoughts about the potential CNS activity in the preventative setting?
Yeah, no, I think that's such an important question. And in fact, something that we saw in the readout as well from DB05, that not only did we see, IDFS, DFS, But we also saw some distant recurrences, including CNS recurrences, favoring the T-DXd arm compared to TDM1. And that's where I think the Catherine data fell short a little bit, that we did not necessarily see that. We still saw 5% of the patients with CNS as the first recurrent site. But it was encouraging to see that at the current readout itself, we're able to see that. Not surprising also, given at least we've seen robust activity in CNS metastases for treatment purposes. We don't necessarily have a lot of prevention data yet with T-DXd, but to see that there were improvement even in CNS recurrences in this data set was very encouraging to see. We have trials such as COMPASS residual disease through the Alliance that is ongoing, where patients get THP, could get an anthracycline, but for residual disease, they then get TDM1 plus tucatinib, which is a TKI, and we can expect activity there, but maybe expect activity for prevention. We'll see what that readout looks like, but I think it was very impressive and encouraging to see even impact on CNS recurrences with the DB05 data set.
Absolutely, very, very exciting. So a lot of new data, and thank you for walking us through that in the early stage setting. That will conclude our conversation, and I want to thank Dr. Jhaveri for your very insightful comments and this wonderful conversation. I'm excited for the field and for our patients as well, and I thank you all for listening.
Thank you so much.